just as a final question, if someone's been watching this and they're living with persistent headaches and they've talked to their GP, they've talked to their neurologist, they've ruled out all those sort of more sinister potential reasons, but they still haven't found answers yet, what would you like them to know?
Yeah, you need to get a vision exam. I mean, that's probably the one workup that hasn't been done yet. So getting a thorough vision exam that includes sight, refraction, which is prescription, binocular visual function, your accommodation function, obviously sort of eye health. So making sure you've got all of those sorts of things covered would be a great idea.
Headaches are one of the most common reasons adults and teenagers seek medical advice. Often they have scans which come back clear, eye health checks appear normal, yet the pain continues. Today I'm joined by Paul Graham, Principal Optometrist at Harmony Vision Care on the Gold Coast, to explore an often overlooked but persistent cause of headaches, binocular vision dysfunction or BVD, and what happens when the eyes and the brain aren't coordinating efficiently. For those who are new to the channel, my name is Paul Salloway. I'm the owner of Optics Digital. We're an agency that helps eye care professionals to grow their practice through connecting with their community. So Paul, great to speak with you again.
Likewise.
So Paul, headaches are a pretty common thing, and persistent headaches can have multiple causes, and of course it's important to rule out what those causes might be. But I feel like binocular vision dysfunction and like that when your brain and your eyes are out of sync is something that doesn't maybe get talked about enough. So could you walk us through what's actually happening in someone's head when their eyes and brain are out of sync, and why does it trigger headaches?
Yeah, and look, the sort of unconsciously your brain is picking up that something's out of balance, and when you've got a binocular visual dysfunction, it's a loss of coordination or an effortful coordination between the two eyes, and it's not just the convergence part of it. It's also when you look at something, you need to line up the eyes into the same area of space, but you also need to have your focusing line up as well. So you've got those a couple of systems that sort of have to stay in coordination, and they're meant to kind of ebb and flow and sort of flexibly work with each other. Now, if they become out of balance, either the two eyes out of balance with each other, or the convergence system is out of balance with focusing, then that creates extra resources that you have to start concentrating. You have to start concentrating on not making errors, maybe in depth perception, making errors when you're moving your eyes across a page, those sorts of things. And that increases internal stress and tension. And the way that our brain kind of elevates the warning is through a headache.
So is it something that people are consciously aware of, or is it something that's sort of happening beneath the surface that we might not be aware of?
Yeah, and I think that, and we can talk about that. You voluntarily, if you keep going at a particular activity that you find difficulty with, there's a subconscious kind of drive to keep going with it, and so it is relatively unconscious, even though there's a bit of effort involved. I don't think people sort of realise what's going on. They're pushing themselves, but not realising they're actually pushing their visual system.
And so when we talk about binocular vision dysfunction, that doesn't necessarily mean that people might be seeing double vision, does it?
Yeah, and look, that's long been one of those symptoms. And I remember, when we did our training, or you read textbooks on binocular vision, and it's like double vision being one of the symptoms, and you kind of go, it's one of the really extreme symptoms. I think there's this idea that, if binocular vision breaks down completely, then yes, you do get double vision, but that's kind of the fight that people are having. They're fighting it going double, they're fighting it going blurry, and it's the fight that creates tension, eye strain, and then the headaches that go along with it. And so someone coming in with eye strain and headaches means, and even blur and double vision means that they're really persisting at a task. There's something that they're really trying to get done. They're trying really hard to make something happen, because other people may decide to give up. It doesn't feel comfortable to do, and they don't reach a point of headache, and so they just give up instead, or they back their performance off to some level it's not quite so stressful. But yeah, I think you'd have to have a reasonable degree of breakdown for it to land at double vision. So there's so much happening way before double vision occurs, unless you're dealing with the kind of binocular vision dysfunction that comes from having an injury like a brain injury, whiplash, concussion, where it's a more sudden onset kind of double vision, because that's a big shock to the system.
So the types of binocular vision dysfunction that you see, is that something that affects mostly kids, mostly adults, seniors? Like, are there any sort of like age patterns where it matches?
No, it's probably more related to tasks. So, any task that you spend a long time doing that you find challenging to do can result in a headache. I mean, you probably more associate it in situations where there's a bit more high pressure. So it's going to be school aged through to working aged. Someone who may be retired may not sort of have the same level of kind of drive to be doing an activity at a level that creates those kind of symptoms, or they might be doing more pleasurable symptoms. And so there's some of the things you need to tease out that, you see it clinically, and I've seen it sort of looked at in research, is that there is a difference in symptoms between someone doing what we call required activities versus pleasure activities. So required activities would be studying, having to read a textbook, having to do computer work that's related to some sort of time pressure, either study or work. And then if you go and spend an equal amount of time gaming, reading a book for pleasure, or doing some other activity that doesn't have the time pressures, the stress pressures, the cognitive pressures in the background, one will create a headache and the other one won't. And so it can get quite complex and confusing as to why, they don't get a headache from gaming for 2 hours, but they get a headache from 15 minutes of reading. And on the surface, you kind of go, well, there's similar distances, there's similar levels of attention involved, but the type of task, and you can even deep dive into your own self-appraisal of the task. If you already think it's going to be stressful, then one might argue that might increase your chances of getting a headache.
Right.
If you find the task unpleasant, then one might argue you might increase your chances of getting a headache.
Yeah. I know, like I feel onset of headaches when I think about doing my tax every year. So yeah. So headaches are something that we have to treat seriously, and there could be many reasons for it. So some are physiological, some related to the eye, and some related to the eye in the sense of coordination between the eye and the brain.
Absolutely.
So a couple of years ago, I was getting these headaches, persistent headaches at the back of my head, and which was, of course, a concern. And I went to the doctor, and they did one of those MRIs, and he showed me the images and says, "Look, you're fine. I think it's just like a tension headache because maybe you've been sitting at the computer a lot recently." And yeah, that's exactly what it was. So can you like talk us through like what are some of the things that people should do when they're trying to sort of rule out potentially more sinister explanations for the headaches?
Yeah, look, and if you're getting a persistent headache and you haven't been able to tie it to a particular activity, I mean, diagnostically from the kind of vision headaches we're looking for, quite often it's tied to the kind of tasks you're doing. It might be more middle of the day, end of the day, if it's related to work, study, those sorts of things. But any headache that sort of persists and keeps going, you need to kind of think about getting some medical attention to that. And optometry has a role, even if it's not a vision headache, for helping rule out any sort of signs of the more serious pathological reasons. Reasons for a headache, we can look inside the eye, make sure the optic nerve looks fine. Depending on the presentation, we can look at a visual field test to make sure that there's been no visual field loss. That might indicate something sort of more serious. So we have a role to play there, particularly if you start adding in waking up with headaches, if you're getting nausea, if you're getting dizziness. I mean, that starts to escalate. You really need to be getting medical attention when you start adding those other symptoms into it. And so there's that place. But if you've been through the sort of process of having it medically diagnosed and you're still getting these sort of headaches and you haven't had an eye exam, then that's a good place to start, because it may well be that it's a vision problem, whether it just be, sometimes a minor prescription problem can create headaches in some situations. It might be we're looking for dry eye, might create headaches in some situations. I've certainly experienced that myself, where I've gone through periods of having dry eye, and if you're trying to keep working through it, is it the blur that the dry eye causes? Is it just the discomfort, and therefore over time you get a headache from just the strain of the discomfort? Is it the brow ache that you're getting from trying to peer and keep going with the work despite the dry eye? And you have similar sort of behaviours when you're doing when you get headaches from eye strain from binocular visual dysfunction. It could be that you're just doing a lot of near work, and eventually your eyes get tired and strained, and then you get a headache. And so tension sort of involves all of these things. So what we would have a look at is, do you have a sight problem? Do you have a binocular vision or accommodation problem that matches the kind of headache and the timing of the headache you're getting? And then we do all the health checks as well to rule out anything more sinister, which are rare, but the consequences can be quite high. And so that's where we want to be sort of alert enough to sort of seek care, but don't worry until you get it, kind of thing, unless you're getting those other, like I said, nausea, vertigo, more serious kind of roll-on symptoms that are going along with it.
So let's say I'm a teenager who gets headaches doing homework, or an adult who can't get through the workday without pain. How do you actually test for this? Like, what happens in the exam room that's different from a regular eye exam?
Well, I'll probably say, some of the things that are necessary. Good case history is finding out when do you get a headache, and I would hope that all eye exams have this as a good case history. Is that when are you getting the headache? How often? What part of your head are you getting the headache in? Because when you deal with headaches a lot because of vision problems, you also start to get a bit of a sense when it's not that the way the headache's being described is not a vision related one, and then we can make some recommendations, referrals, those sorts of things. I mean, we talked about, getting an occipital headache. Some people get a referred pain to behind the eye with something like that. And that might be something that might need another professional related, some sort of physical examination of neck and jaw and shoulders and those sorts of things, heading through the GP to be sure, but making those kind of suggestions. And so, time of day, frequency, what other symptoms are you getting, what gives you relief from the headache. And probably a good point here is to kind of go, we need to kind of differentiate between sort of bad headaches and migraines, which becomes a different sort of kettle of fish. So then we would do your regular things of, do you see well on the letter chart? So, how well you see down a letter chart is ruling out pathology and ruling out whether you've got just a basic refractive problem, whether you've got some uncorrected astigmatism or long sight or short sight. What we concentrate heavily on in our practice is then doing a very thorough assessment of your binocular vision. How well are your two eyes working together? Do you have good 3D perception? Do you have good focusing skills? Is there good flexibility between your binocular system and your focusing system? Because that's where we're really going to find if a headache is related to the eye strain that comes with binocular visual dysfunction. And then after that, then again, we hope this happens in every eye exams, is that we're going to do a good exam on looking at the back of the eye, how healthy does it look, just making sure that there's nothing else that might give off the sort of the same symptoms.
Yeah, you mentioned a referred pain there. I remember I'm disclosing a lot of my medical history here. So a few years ago, I had a pain in my leg, and I went to the doctor about it, and she said, "Oh, maybe that's an issue with your lower back." And I'm like, "No, it's in my leg, not my back." And then she explained that the nerves are all sort of connected, and just because we've got pain in one area, it might be arising from something else. So from what you're saying, it sounds like the same thing happens with our neck, our head, our eyes, all of that as well.
And again, we don't want to take anyone taking that as prescriptive advice for their own situations. General discussion here, but you can get all sorts of things. And I've seen studies in dizziness and vertigo where sometimes it ends up being a binocular vision dysfunction and not something more sinister or something else. So, what I talk to my patients about is that I kind of look at this as the functional unit of seeing. Okay, and your visual system, in order to understand what's going out there visually, needs to know what parts of you are moving and what parts of the world are moving to kind of really understand how this light's moving across the back of the eye. And so if you've got dysfunctions elsewhere, that can then project into creating problems in the visual system. You've got neck tension. There's been a fair degree of study over time that when you push hard with your focusing, you get neck tension. And so you get all these sort of associations that you want to be able to sort of tease apart. One of the things I look for if someone's getting those sort of, it sounds like neck tension, tight neck, tight shoulders, do they have a vision problem that's causing them to change their posture or hold tension while they're doing an activity? So there may be a visual element to it, but the physical kind of expression is through another part of the body.
Right. Well, if you're watching this on YouTube and you're getting value from the discussion so far, could you do us a favor? Would you please hit the like button, because it really helps us out with the algorithm and increases the chances that other people might also benefit from the conversation. All right, Paul. So if someone is diagnosed with BVD, binocular vision dysfunction, what does treatment actually look like in the day-to-day sense? Are we talking about glasses that they need to wear? Are we talking about vision therapy exercises or something else? So realistically, what kind of improvements should people expect and on what timeline?
Yeah, and obviously we need to have the individual in front of us and their individual circumstance and individual sort of findings. But if we break it down into what sort of tools do we have available, and tools we mean what can we prescribe and what sort of advice can we give? And so if we've identified that it's a binocular visual dysfunction or an accommodation problem, which implies that it's out of whack with the binocular visual system, where we're comfortable that everything else about the person's visual system is healthy and everything looks okay, then we talk about, okay, well, a lot of the headaches that you might get from binocular visual dysfunction is the sheer amount of near work that you're doing. And so let's have a discussion around simply just that, so taking breaks frequently. And we've talked about this on other videos, is that, there's a cute rule, the 20-20-20 rule, which is every 20 minutes, look away 20 feet for 20 seconds. Now, it sounds great, and I think it's good advice, but it might have its limits on the practicalities. And so I certainly think that if you wanted to get a longer period of time for getting some work done, if you go 45 to 60 minutes, but then take a decent 5 to 10 minute break, is some general advice around trying to avoid both tension headaches and vision headaches, because you're getting moving again, basically. And so that's one of the things we look at is breaks. Have you got good lighting? How far away is your screen? Looking out for, how is your workstation sort of set up and those sorts of things. So you've got those things that the person can take control over. is how much intensity of work are you doing in one moment, and what adjustments can you make to manage that. And then we look at, well, what tools are available from a prescription point of view. So let's assume if you've got a mild refractive error that we think is contributing to headaches, then we'll talk about prescribing that. We may find that certain types of binocular visual dysfunctions do benefit from like a mild reading prescription, and people worry that that makes their eyes weak and dependent, and I simply don't see that happen. Because and the way I look at it, that if you are careful in the way you prescribe those kind of lenses, they're a bit, I call them the ergonomic chair for the eye. They're basically providing some assistance to make the near task more comfortable, and that you might only need to use them for those intense kind of near tasks. So that might be something that we would consider based on the individual circumstances. And then we would tend to, in our practice, we would tend to use vision therapy for someone where the dysfunction has gone far enough that taking breaks is not going to work. Prescription's really not going to do enough, and then we have to effectively rehabilitate and have someone develop better visual skills again. It could be that some people didn't develop them properly to begin with. Someone might have had a mild whiplash, mild concussion, not realised it's created this. Sometimes it's just created from doing lots of near work, and it gets to a point where they're kind of stuck. And using different analogies for different things. I've got my ergonomic chair analogy. The other one is that, and take personal experience, busted my knee at 19. Developed a change in the way I stand and the way I walk because of it. The injury is long gone. I'm certainly not a 19-year-old anymore, but the patterns of how I move and how I stand still persist. And so in order to change that and get back to a more balanced way of standing and sitting, I've got to do some active rehabilitation. And so sometimes what happens and the change in function can go too far, that we need to do something a lot more active to rebuild it and put it back to something more normal looking.
Now, are prism lenses also part of your toolkit? And I think you've got some strong thoughts about prism lenses. So first of all, can you explain what they are, and then whether or whether you don't use them?
I've probably got some samples in there. Prisms look and sound simple in theory, or in sort of just looking at them. And so you would never prescribe something looking like this. But and for those of you who are into music or old, you might remember the Dark Side of the Moon,
Pink Floyd.
Pink Floyd cover, where you see the prism breaking up light, and certainly you can sort of set up a situation where white light's broken into rainbows, but in much smaller amounts, much smaller degrees of prism, you don't quite get that kind of impact and effect, particularly if you put it within a curved lens. But effectively, what a prism does is bend light in one direction. I wonder if this will work here, but if you can look at the computer monitor on this side, see if I can get it to work, where the direction of the prism, I might actually go something smaller, might work a little better, where you can see the stand has been pushed sideways. Right. Okay, that little section of stand in there is pushed sideways. And so it's bending light in a particular direction. So it bends light towards the tip. So if we're prescribing a lens with the thick part towards the nose, okay, then the light is being pushed that way. And so I have to make a movement of my eyes that way to bring the alignment back together again. So one of the theories is, if your eyes are doing this to begin with, we can pop prisms in to match. Now, there are certain circumstances where that works quite well. And so if you've got a vertical imbalance, okay, we don't have as much movement this way, prisms in particular can be quite useful in that sort of situation, where someone can't bring their eye down, so you bring the world down through the prism, and now I can get the two eyes working together well again. There is a lot of toing and froing in the research about whether horizontal prism for eye teaming problems that are more regular, the convergence excess, convergence insufficiency, are all that useful, because we often see a situation where people eat prism, where we kind of go, well, you come in, we prescribe a certain amount of prism, it seems good initially, but then you come back later needing more because we haven't got to the heart of the problem. And then there's other things that go into that. Once you start getting up into high prisms amount, they look really simple. They're these flat things. They've got two surfaces. They push the light that way, but they bend light in very interesting ways. They're one of the most complex lenses you could prescribe. And so when you start getting into higher powers, you're adding all these other things that you're not knowing how to control. And so I use them judiciously. And that's probably the end story. We use them a lot for testing, but prescribing them, I like to be pretty careful about what we expect from them. So they certainly have a place, but they're not the magic bullet that are sometimes made out to be.
Well, just to go back to vision therapy, just briefly, do teenagers and adults respond differently in terms of like their adaptation? Like, do younger brains adapt more quickly than, let's say, older adults?
Good question. I think sometimes when we're dealing with an adult, we're dealing with a vision problem that may well have started earlier and they've just carried on through. Broadly speaking, we don't see age as a barrier to benefiting from doing vision therapy when you need it. I think my oldest patient would have been 89. So you kind of go, sort of age is not a barrier, that old cliche. Certainly things change though. So if you're talking about adults in my vintage, where we're at that kind of age where our focusing flexibility is naturally declining, and it's not because of a dysfunction, it's because of just the lens inside the eye getting hard. And so it doesn't change shape anymore. So that alters how someone might be expected to respond to some of the activities we do. So it means that some of the activities we're using might be, it could be just we have to label the instructions a bit differently for them, or have them pay attention to something a bit different as part of the therapy process. So I guess the short answer is, there are variations, but the overall theme of what we're trying to achieve with vision therapy based on age is fairly similar. So the younger kids, you might be working with some general eye movements that are part of their binocular visual dysfunction. Often, if we're able to catch kids early in the process of going down the path of developing some binocular dysfunction, we might avoid needing to do vision therapy, because we can kind of short circuit what we think the process is why they're heading down that way. And so I guess that's another aspect that might be different with kids, is that we get in early, then we might be able to change the path.
All right, thank you. Well, can you explain why someone's headaches might get worse in certain environments? For example, are there things like fluorescent lit offices or grocery stores or driving at night? So what is it about those situations that might trigger particular headaches from binocular vision dysfunction?
Yeah, so it's an interesting one, because chicken and the egg is do they have this overarching sensitivity that the binocular vision is just part of, and then so they're sensitive to movement, they're sensitive to changes in visual space. There is some research looking at things like fluctuations in your accommodation system being different in those kind of circumstances. There appears to be some people who have binocular visual dysfunction who have this thing called pattern glare. And I think that's where the flicker and shopping centres and pattern surfaces can be uncomfortable. Again, you can have pattern glare without binocular dysfunction and vice versa, so they're not always tied together. Not everyone who has pattern glare has binocular visual dysfunction and vice versa. But people might be sensitive to these kinds of patterns, pattern surfaces, and text can be a trigger for that. And so that's another thing that we kind of are looking for, that if things aren't adding up, it sort of sounds like a binocular visual dysfunction, everything seems to be okay, then, we start to get a sense from those kind of, what do you like in shopping centres? Do you get a bit of motion sickness? Do you get a bit of car sickness? So you find flickering lights annoying, that might lead us to kind of go and, okay, well, maybe it's a pattern glare issue as part of this whole, headache, sore eye kind of cascade that we're sort of looking at.
And so, like, obviously we can't just avoid going to shopping centres. So are there any practical strategies that patients might use to sort of reduce these triggers if there are, certain environments that are problematic for them?
Yeah, look, some people end up finding, if we can manage the binocular dysfunction, we think that's part of it. And obviously that's one of the things that we need to sort of deal with. So get examined and just see if there are things there. There are some people in those situations where they might find certain colour tints that we test them with make pattern glare less glare inducing. And so they might find light tints and those sorts of things. Again, we need to individually kind of work that out. In terms of self strategies, often if you've got some issues around shopping centres and things like that, going at quieter times can be useful. Perhaps going to shopping centres where the lighting's a little bit more natural. Ones where the surfaces that are used aren't quite so patterned, they're a little bit more bland. I do wonder if there are things like, how stressed you are, making it better or worse. So just having a little bit of a listen of, if I'm feeling pretty peaky and stressed at the time, maybe this is not the time to be going to the shopping centre. So in terms of own avoidance sort of strategies, I would certainly look at, times when there's more natural light, times when there's less people, and that's going to vary obviously from wherever you live and wherever your local shopping centre is.
All right. Well, just as a final question, if someone's been watching this and they're living with persistent headaches, and they've talked to their GP, they've talked to their neurologist, they've ruled out all of those sort of more sinister potential reasons, but they still haven't found answers yet, what would you like them to know?
Yeah, you need to get a vision exam. I mean, that's probably the one workup that hasn't been done yet. So getting a thorough vision exam that includes sight refraction, which is prescription, binocular visual function, your accommodation function, and obviously sort of eye health. So making sure you've got all of those sorts of things covered would be a great idea.
Okay, Paul. Well, thanks again for a really balanced explanation of a condition that many people maybe haven't heard of yet but are experiencing. So if someone's on the Gold Coast and they'd like to talk to you more about binocular vision dysfunction, how can they contact Harmony Vision Care?
Okay, so we've got harmonyvisioncare.com.au as our website. We're on Facebook and Instagram. You can call the practice on 0755205900. If you're wanting to book an appointment, then again, if you go to the website harmonyvisioncare.com.au, we've got the ability to book online from there, which will prompt a call from the staff to discuss what your needs are and get you all booked in.
And if this conversation has helped you to have a better understanding of one potential cause of persistent headaches, then please like, subscribe, and share this with someone else who might benefit. Well, thanks for watching, everyone, and we'll see you next time. Bye, Paul.
Thanks again, Paul. Thanks, everyone.
Bye for now.